So when we talk about diastolic function as opposed to systolic function, I'm going to show you what we're talking about. Okay, so we're going to go over the Doppler signal for systolic and diastolic function. So if you recall, when the Doppler signal for LVOT flow looks something like this. So when you get LVOT flow across the left ventral flow tract or across the aortic valve opens, okay, and you get blood accelerate and then it decelerates. Blood flows across the left ventral flow tract and then across the aortic valve into the aorta. So this point here represents the opening of the aortic valve, and this represents the closure of the aortic valve. Okay? So remember, this is what the LVOT Doppler signal looks like, and it's below the baseline. If we're doing it in the 5-chamber view, the blood is flowing in the opposite direction from the transducer. That's why it's below the baseline. And if you recall earlier lectures, we talk about when you have the end of systole, the aortic valve closed, but the mitral valve is not yet open. There is an interval we call the IVRT, okay? And we're gonna just look at the signal for a normal individual. So this interval here is what we call the IVRT, okay? So let's highlight it a little bit. So this is the IVRT, isovolumic relaxation time or period, IVRT. Okay? So aortic valve open, blood flows across the left ventral flow tract, then the aortic valve close, nothing happens, okay? The aortic valve is closed, the mitral valve is closed, so there is no volume change. Then the mitral valve opens, and you get a suction of blood from the left atrium into the left ventricle, and we call this the E wave. Okay? So suction of blood from the left atrium into the left ventricle. Then you have equalization of pressure between the left atrium and left ventricle. This is what we call diastasis. Diastasis, okay? Stasis. Okay, so diastasis. Equalization of pressure in the left atrium and left ventricle, so there's no flow. And then the atrium contracts, and you get an additional amount of blood pumped into the left ventricle. So all of this here comprise diastole. The IVRT, E velocity, diastasis, and the A velocity or A wave. So all of this comprise diastole, okay? So if you have diastolic dysfunction, you expect to get a change in these parameters. In addition to these parameters, if you remember when we talk about tissue Doppler imaging, we look at the medial and the lateral mitral annulus. When the heart contracts, the base of the heart moves up towards the apex. And when the heart relaxes, the base of the heart moves away from the apex. When the base of the heart moves up towards the apex, okay, let me draw that again. So this is our mitral inflow right here, the mitral inflow. So this is your mitral inflow. And then we're going to look at tissue Doppler imaging. So everything we taught you about Doppler, we're going to put it together to look at diastolic function and dysfunction. So if you remember your tissue Doppler imaging, when the base of the heart moves up towards the apex, we talk about S prime, okay? Okay, so we talk about an S prime. So the base of the heart moves upwards, it moves towards the transducer, so we get a S prime. And in diastole, the base of the heart moves away from the apex, and we have a early diastolic component. We call that the E prime. And then we have a late diastolic component we call the A prime. So this is E prime, and this is your A prime. A prime. So this is when, again, when we talk about tissue Doppler imaging, we look at the speed or the velocity of the tissue, and we use the mitral annulus. We can either do it at the medial mitral annulus or the lateral mitral annulus. In systole, the base of the heart moves up, so we get an S prime, systolic component. In diastole, we get an E prime, early diastolic phase, and then a later diastolic phase, A prime. There are normal values that you need to know for a normal heart. So the normal heart will have a certain value for IVRT. It's supposed to have a certain value for E velocity, a certain value for the E wave, a certain value for the A wave. And similarly, for the tissue Doppler imaging, your E prime and your A prime is going to have a certain value. So when we talk about diastolic dysfunction, these numbers are abnormal, okay? There are other things that we look at when we talk about diastolic function and dysfunction. Again, in systole, the heart contracts, pumps. In diastole, the heart's supposed to relax and accommodate blood. When you have diastolic dysfunction, one of the earliest things to happen is impairment of relaxation. The heart does not relax properly. Okay? And if that diastolic dysfunction gets more severe, then you're going to have a problem with compliance. The atrium is going to get less compliant. But when the diastolic dysfunction gets more severe, the atrium gets bigger and bigger. Okay? So the atrium gets larger and larger when you have diastolic dysfunction. Well, the worse the diastolic dysfunction. Also, the TR velocity, the pulmonary pressures. The worse the diastolic dysfunction, the pulmonary pressures get more severe. And remember, we use the TR velocity to measure the pulmonary pressures. The TR velocity we use to measure the pulmonary pressures. So the worse the diastolic dysfunction, the greater the TR velocity, the greater the left atrial volume. And we also look at the pulmonary vein flow. If you remember, when we talk about pulmonary vein flow, that is the flow of blood in the pulmonary vein going to the left atrium. In systole, you get a component looking like that. And then in diastole, you get a component a little bit smaller. So you get a systolic component, pulmonary vein flow, and you get a diastolic component. Okay? And this is your pulmonary vein flow. So this is what a normal pulmonary vein flow looks like. Systolic component a little bit larger than the diastolic component. As the diastolic dysfunction gets more severe, the systolic component gets less and less and less. Okay? Similarly, or opposite to that, the worse the diastolic dysfunction, left atrial volume gets larger and larger and larger. And the TR velocity, which is a reflection of the pulmonary pressures, is get larger and larger and larger. So we can categorize diastolic dysfunction in terms of severity. And we use a grading system, grade 1, grade 2, and grade 3. And we're going to go over that. Okay? But basically, we use these assessments or these parameters to grade the diastolic dysfunction. And with that background, we're gonna show you how we do it, okay? All right, so this is the American Society of Echo paper, and I'm just gonna erase this. Okay, so basically, it's the AC recommendations and assessments we're going to use, because and most other governing body use the American Society of Echo. All right, so we're going to start here because I sort of give you some background information. So the application of the guidelines starts with taking note of the clinical data. That is, when the patient comes to the echo lab, or if you're the doctor who is taking information, you need to know the heart rate, the blood pressure, and then the 2D and Doppler findings with respect to left ventricular volume, wall thickness, ejection fraction, left atrial volume, the presence and severity of mitral valve disease, as well as the underlying rhythm. Essentially, what they're saying, you're going to do a normal study. You're going to do a complete study, and you're going to take the clinical information from the patient, that is, the vital signs. The guidelines are not necessarily applicable to children, however, or in the peri-op setting. So what we're going to talk about is not applicable to children or, after the patient had an operation. So this is an important first step because there may be recommendations that are specific to the underlying pathology. Second, the quality of the Doppler signal, as well as the limitations for each parameter should be carefully examined. So you have to do it properly, because if you don't do it properly, you're going to use your faulty assessment to assess the patient. If a Doppler signal is suboptimal, the signal should not be used in formulating conclusions about LV diastolic function. So do not use it if it's not accurate. So you need to know what an accurate Doppler signal should look like and how to do it. Third, the presence of a single measurement that falls within normal range for a given age group does not necessarily indicate normal diastolic function. So we're going to look at a group of stuff, okay? A group of parameters, and we use a number of them to make the assessment. So given the several hemodynamic factors that affect each signal, some measurements may fall in the normal range despite the presence of diastolic dysfunction, and none of the indices should be used in isolation. So do not use just one of the parameters. You have to use them in a group. Therefore, consistency between two or more of the indices should be relied upon in individual patients. The echocardiographic indices of diastolic dysfunction should always be interpreted in a wider context that includes the clinical status and the other two-dimensional and Doppler parameters. So you shouldn't make an assessment of diastolic dysfunction without taking into consideration the clinical status of the patient, the 2D and the Doppler parameters. Although often overlooked in reporting, the underlying pathology shown by 2D and color flow Doppler is critical to reaching the correct conclusions about LV diastolic function. So essentially, you're going to do a complete study, your two-dimensional, your Doppler. Okay, so you need to know how to do a routine study, do everything, and you're going to make sure you get a basic history from the patients. You're going to do vital signs. Okay, for example, the algorithm for estimation of LV filling pressures is less likely to be helpful in a patient with normal vital signs and normal 2D and Doppler findings. So if everything is looking normal, you probably shouldn't look for LV filling pressures, because someone with LV filling pressures, an elevated pressure in the LV, will usually have probably shortness of breath with exertion or shortness of breath at rest. So the clinical picture is important. With respect to the grading of LV diastolic dysfunction, it is the recommendation of the writing group to determine the grade of diastolic function based on the presence or absence of elevated filling pressures as a first step. So what we are saying is that, okay, very mild diastolic dysfunction, the LV filling pressures, and when we say the LV filling pressures, when you have systolic heart failure, that is the contractility of the heart is depressed. Because the contractility of the heart is depressed, the pressure inside the left ventricle is going to increase. And when the pressure inside the left ventricle increase, then it dilates the heart, and then that dilatation of the heart will cause contraction, the so-called Frank-Starling law. So one of the hallmark of systolic heart failure is elevated LV filling pressures, that is the pressure to fill the left ventricle. Similarly, when you have LV diastolic dysfunction, the worse the LV diastolic dysfunction, the greater the filling pressures. So remember, when we talk about diastolic dysfunction, we talk about problem with relaxation, the muscle is not relaxing properly. And then as it gets worse, you have a problem with compliance. It becomes non-compliant. So very early in diastolic dysfunction, the filling pressure is normal. But as you start getting more severe diastolic dysfunction, the LV filling pressure becomes greater. So when you're assessing someone for diastolic dysfunction, it's important to determine, do they have elevated filling pressures, yes or no? Because if they don't have elevated filling pressures, they're going to have early diastolic dysfunction. If they have elevated LV filling pressures, then they're going to have a later stage or grade of diastolic dysfunction. Okay? So with respect to the grading of LV diastolic dysfunction, it is the recommendation of the writing group to determine the grade of the diastolic dysfunction based on the presence or absence of elevated LV filling pressures as the first step. Okay? While useful in some cases, the lower feasibility and reproducibility of flow propagation velocity and time intervals led the writing group to place less emphasis on their routine acquisition analysis. So basically, we are not using the flow propagation or velocity, anymore. Essentially, we're not. The writing group strive to recommend algorithms that are applicable to most patients with cardiac disease. Notwithstanding this effort, the algorithms are not 100% accurate. For the most successful application of the guidelines, it is incumbent on the echocardiographer to have a solid understanding of the physiologic rationale behind each variable, the situations that make any given variable less reliable, and the technical aspect in acquisition and analysis of Doppler and tools. So you do a very good study. It's important. The following sections are applicable to the general population of patients seen in an echo lab, but not in the presence of specific diseases or rhythm disorders, which are discussed separately. So the grading system that we're going to give you is for a general patient, but in certain disease conditions, it may not be applicable. I will tell you which one, the conditions that fall outside of this general rule. Okay, so the differentiation between normal and abnormal diastolic function is complicated by overlap between Doppler indices values in the healthy individuals and those with diastolic dysfunction. So you're going to have some amount of overlap. Furthermore, normal aging is associated with a number of changes in the heart and vascular system, especially slowing of LV relaxation, which may lead to diastolic dysfunction. So what we're saying is that as one age, there's a problem with relaxation, LV relaxation. So you have to take the age of the individual into account when you're doing these assessments. Therefore, filling patterns in the elderly resemble those observed in mild diastolic dysfunction in younger patients at 40 to 60. Okay? So the older individuals will have certain patterns that look like they have diastolic dysfunction. And age should be taken into account when evaluating diastolic function variables. Okay? We're not going to go into this in detail, but the mechanism of diastolic dysfunction in LT sedentary elderly appear to be due in part to the increased LV stiffness compared with younger individuals. So the older one get, the LV becomes stiffer. Presumable, there is also slowing of myocardial relaxation in the elderly, which can account for the decrease in the mitral E to A ratio and E prime velocity. So as one gets older, the E gets smaller and the A gets bigger. And you may also get a decrease in your E prime velocity as well. But the data on aging and relaxation are not entirely consistent across the studies. Furthermore, apparently LT older individuals may have undetected coronary artery disease or other subclinical disorders that could lead to the wide normal ranges. Some indices, however, are less age independent, less age dependent. Some indices are less age dependent, and this includes the ratio of EE prime. So remember, we talk about the E is your mitral inflow E, and E prime is your TDI E prime. This ratio is less age dependent, okay, which is very rarely greater than 14 in normal individuals. So if you get an EE prime ratio which is greater than 14, it is telling you that you have an increase in your LV filling pressures or increase in the left atrial pressure. So it's important to note this ratio, EE prime, okay? It is less age dependent. And if it's greater than 14, it suggests that you have an increase in your LV filling pressure or left atrial pressure. Changes in the mitral inflow velocity with Valsalva maneuver is also less age dependent, and the difference in duration between the pulmonary vein atrial flow reversal velocity and the mitral A velocity. So these are less age dependent. The Valsalva maneuver can help distinguish between a normal filling pressure and a pseudo-normal, and we go over that, so don't worry about that. Basically, what they're saying is, older patient comes and the E velocity is low and the A is high, and you suspect diastolic dysfunction. You can do the Valsalva maneuver, and it will help you to distinguish normal from pseudo-normal, and which is it is more helpful when the older patient presents with a E which is greater than the A. Remember, normal individual are going to have an E velocity which is greater than the A velocity. Older individuals shouldn't have that pattern, and we call that pseudo-normal. We'll go over all of that. But when the E velocity is greater than the A velocity, that should be a young person. If you see that in someone who is over 50, 60, that is abnormal. And you can show that it's abnormal by doing the Valsalva maneuver. And when you do the Valsalva maneuver, then you'll see the diastolic dysfunction. That is, the big E will now get small and the A will get larger. Okay? So we'll go over all of that so you'll fully understand that. Because a decrease in the E to A ratio of greater than or equal to 50%, not caused by E and A velocity fusion, is either specific for increased LV filling pressures and supports the presence of diastolic dysfunction. And we're going to go over the Valsalva maneuver fully so you can understand how you can use it to distinguish whether you're talking about a normal patient or someone who has diastolic dysfunction. The procedure should be standardized by continuously recording the mitral inflow using pulse wave Doppler for 10 seconds during the straining phase of the Valsalva maneuver. Likewise, an increase in the pulmonary vein atrial flow reversal duration versus the mitral A duration is consistent with increased left ventricular end diastolic pressure and diastolic dysfunction. So we will go over that in its entirety, so you understand again. So pulmonary artery systolic pressure, that is when we measure the TR velocity, provided pulmonary vascular disease is excluded, can identify patients with increased LV filling pressures. Because when the LV filling pressures get larger or greater, the pulmonary pressure is going to get larger or greater. As resting values for estimated pulmonary artery systolic pressures are relatively age independent. In many patients, LV and LA structural changes may help differentiate between normal and abnormal diastolic function, similar to the left atrial enlargement. So we went over that. Similar to left atrial enlargement in the absence of chronic atrial arrhythmia, which is often a marker of long-term or chronic elevation of left atrial pressure. So if you have no obvious cause for the left atrium to be enlarged, you can relate it to diastolic dysfunction. Pathologic LV hypertrophy is usually associated with increased LV stiffness and diastolic dysfunction. Furthermore, in patients with heart failure with preserved ejection fraction, that is, they have heart failure, but the systolic function is normal. Okay, so we call that heart failure with preserved ejection fraction, FPEF. Okay, LV global longitudinal function is usually impaired. So the LV global longitudinal function is usually impaired in these individuals, and thus it may be used to differentiate between normal and abnormal myocardial function. We'll go over that in detail, don't worry about it. Although not an index of LV diastolic function, abnormal LV longitudinal systolic function can be detected by measurements of the mitral annular plane systolic excursion using M mode. So just like when we do TAPSE, looking at the RV systolic function, we can do MAPSE, which is mitral annular plane systolic excursion using M mode. And if it's abnormal, then it may be a marker of diastolic dysfunction, okay? It's an M mode measurement. We can also do tissue Doppler derived mitral annular systolic velocity, just as we do RV systolic velocity. We can use the Doppler derived mitral annular systolic velocity and LV global longitudinal strain by spectral tracking echo to look at the longitudinal systolic function. This approach has not yet been widely tested, but in patients with normal EF and inconclusive data, after evaluating diastolic filling, the finding of impaired global longitudinal strain and reduced S prime velocity can be used as an indication of myocardial dysfunction. The reduced longitudinal strain in patients with HFpEF, which is heart failure with preserved ejection fraction, is consistent with several studies that have demonstrated reduced systolic mitral annular velocity in patients in this patient population. It is also consistent with the fact that LV systolic and diastolic functions are tightly coupled. So essentially, what we have said is that we show you what the normal diastolic parameters are. We look at the IVRT, we look at the E velocity, we look at the A velocity, we look at the tissue Doppler imaging, we look at E prime and A prime. We also look at the pulmonary vein flow, the systolic and diastolic components. We also talk about the TR velocity, which is a surrogate of your pulmonary artery pressures. The greater the stage or the grade of the diastolic dysfunction, the greater the pulmonary pressures, so the greater the TR velocity. the greater or the more severe the diastolic dysfunction, the greater is the LV filling pressures. Okay, so when you look at surrogate for LV filling pressures, left atrial pressure, which is your EE prime ratio, it's going to be elevated. We're going to stop here, and on Thursday we're going to actually look at the grade, how we grade the diastolic dysfunction.